Hi, this is Fernando Gómez Sancha, and this is an interesting case of a man who was submitted to a previous aquablation. This man had an aquablation procedure 2.5 years prior to coming to see me. He had been studied because he was not being very well. He had a urethrogram that didn't show much, and a cystoscopy that showed residual apical tissue and a little bit unfracturous fossa, probably showing that the debulking was not enough to get the patient to improve. He had a urodynamics study where a weak bladder was found, and residual urine was about 200 milliliters, and maximum flow rate was 6 milliliters per second, with a very slow flow, and the patient wanted to be treated. This is a synechia. We see this quite often when the adenoma is not completely removed, but it was getting longer and longer, so I decided to go leave that and go back to the sphincter pillars, lateral pillars, to be able to mark the white line as we usually do. This video was missing in my collection. I don't recall having published a post-aquablation treatment before, and we have published here in this channel, I think, retreatments after most minimally invasive available treatments. I recall having operated patients after ITIND, after Resum, after Urolift, and this was missing from the library. So I was quite happy when I had this patient, thinking that I might be offering this video with yet another case of redo. I have to say that I have also reoperated patients after HoLEP, where probably the apex was not aggressively, removed enough, and I also have a couple of videos, I think, of patients operated after open prostatectomy. So there is a possibility to have a retreatment after most surgical options. And of course, I think it's very important to have in mind that the patient is submitting himself to a second operation, and I think it's a good idea to try to do a definitive treatment if it's possible. Try to release the patient from this suffering, and try to solve the problem once and for all. We can just try. This is what we do as surgeons, try. And here we are. I think that aquablation is being marketed now as a very good solution for men, because it's quite safe, and many patients will keep their ejaculatory capabilities, but there is a chance to leave residual tissue. I did some cases many years ago, and I still follow them up. These patients still are being reasonably well, not as well as when they had the operation, and but the residual volume of their prostates is not as small as what we see when we do HoLEP. When we do HoLEP, the prostate gets down to 15, maximum 20 grams of tissue, and then it doesn't grow. And I think these aquablation patients that I did many years ago are now having prostate volumes about 60-70 grams. So there might be a concern with durability, although they seem to keep up quite well for the first initial years. So to me is very important to, if you're going to do BPH, and if you're going to offer alternative treatment to patients, you should really read the papers with a critical mentality, because there's a lot of industry influence on how these papers are designed, how they are carried out, how they are reported, and sometimes the initial look at the paper might be very positive, but when you start digging a little bit deeper on how the conclusions are supported by the data they present, sometimes there is a discrepancy, and we have to be critical about that and not buy into what industry says, just like that. Now we have to be a little bit critical because we have seen it before. In BPH, in incontinence surgery, there's always this promise of a new treatment that is going to change everything, and then there is this hype. People, jump to use these treatments, and then there is this, lack of validation. When you start using these treatments yourself, you realize that the promise that the industry made about these products is not keeping up to its promise, to its the value for the patient, and then you start probably indicating less and less, or indicating better and better, for the patient, where the minimally invasive option or could be more adequate. In this case, this man, 75 years of age, he had a bulky prostate when he had the aquablation. He had like 70 grams estimated volume. Interestingly, the preoperative volume was estimated now, 2 years later, at 90 grams, so probably there was not much tissue removed. Also, it is possible that the performance of the operation was not totally correct, which is a possibility. Sometimes, like when someone is starting with HoLEP, maybe his execution is not perfect. But I think we have to be careful because there's a lot of industrial influence on published papers, and we have to be careful and, as I say, read them carefully, and probably have a look at the independently carried out studies rather than the industry-funded studies, because when industry funds, probably the influence of the company in the paper is quite substantial. So here we are. As you can see, this was an operation where I didn't have any visitor. Normally in my sessions there's always someone watching operations, so I tend to maybe go a little bit slower and explain a little bit more and stop during the operation. Some of the many or maybe most of the videos that I have published here happen in front of someone, and in this case I was alone. It was a morning list, which is not very common for me, and so I could rush a little bit through the operation without having to explain anything. So you might notice some additional dynamism, you know what I mean? I'm not stopping so much, I'm not being so, let's say, I'm going a little bit faster than I would usually go for a teaching case. But you see, the wonderful thing of the en-bloc technique is that when you get used to the movements, when you get used to the steps of the operation, then it's very intuitive and it's very automatic. I don't know what was happening here. Maybe changing the pedal or something. A little stop there and then continuation. And here, this is now the connection at 12 o'clock. You see, I'm connecting one side with the other side, and I'm noticing that there's some anterior tissue that was left apically. Sometimes, if I see that the plane I took on the other side was not deep enough, I will try to, find the best possible plane. I don't want to leave residual hyperplastic tissue, and sometimes the planes are very, very clear and sometimes not so clear, so you might have to revisit, like I'm doing here. We took a not so deep root before, but now it's being corrected in order to do an aggressive removal of the whole adenoma. All right, so that's the idea. So as a general rule, when you do a redo case, when you reoperate a patient, you should be exploring the capsule completely around the adenoma. Don't just remove one lobe or one. Sometimes you enter and there's a nice looking cavity. Maybe you think, wow, the right side was resected very well, and there's only a bump on the left, so I will remove the bump of the left. No, typically it's much better to go into the plane near the veru and then look around, and you will find that most times there will be a significant amount of tissue left. So here we are now. This is the entry into the bladder neck. You can see the vertical fibers, very easy to recognize landmark. And that's now the work on the bladder neck to try to open up the bladder neck. Sometimes in the redo cases we find that there is some fibrosis in the areas where energy has been used, and after aquablation there has been some coagulation performed at the bladder neck region, some resection. So you might expect to find some fibrosis there. You see the line, the circumferential line of dissection is a good way of getting oriented, and the tissue must have been quite hard, because as you can see I'm doing some contact in the dissection. So sometimes if I feel that the near contact firing is not dissecting fast enough, sometimes I might get quite close to the tissue. Here at the bladder neck level, usually I do contact because I really want to perforate there. I want to perforate into the bladder. I know that if I perforate, it's going to be safe because the bladder is on the other side. So often you see the bladder neck fibers are quite hard, and here I tend to do contact. But for the rest, I usually use a distance that provides a very soft, very careful dissection effect, because we want to recognize if we go deeper or if we go into the capsule a little bit. We don't want to, of course, cause a perforation that has no solution, but I'd rather want to see that I'm getting deeper so I can correct. I'm getting deeper into the peripheral zone so I can correct my aiming in order to try to prevent going even deeper and then maybe establish a perforation. Whenever I see yellow tissue, I explore below it because I want to remove the whole adenomatous tissue, and that brings me sometimes to relatively deep planes with very thin looking capsules, and we have to be careful. Here the aiming is against the adenoma rather than on the capsule, because we want to prevent the energy reaching the capsule and deepening into the capsule, right? So this is the 6 o'clock region, moving from the sides downwards to try to finalize the enucleation. And well, I think if aquablation is being heavily promoted, I think, and you see, for example, the SIU guidelines recently promote aquablation quite clearly. It's the only technique that shows a photograph. It's the only technique that it's mentioned by its commercial name in the guidelines. And despite a lot of evidence recommending HoLEP for all sizes of prostates, this guideline is saying that HoLEP should be used in prostates bigger than 80. And we know that aquablation is specially recommended for prostates below 80 grams, although they now try to expand the indication to bigger glands. So there's a lot of promotion of aquablation, and I think we will get to see more and more cases like this where the insufficient removal of tissue requires a second operation after time. But it seems to be holding well for the first years, but let's see what happens, because maybe the volume reduction that we get with aquablation is not as complete as the volume reduction that you get after enucleation. So that being said, you can see that it's been now 15 minutes of operation, and now we're nearly finishing. So it was a fast case and it behaved very well. And now, of course, I want to check the position of the UOs and make sure to protect the UOs when we detach the adenoma from the bladder neck. Typically, I like to come from the sides until I reach more or less the midline here. I wouldn't want to continue dissecting there towards the other side, because there's a chance to hit the UO from the contralateral side. So I'd rather go from lateral towards medial, like I'm doing now, to finalize the detachment of the prostate. And there we are. Just another case of enucleation. And if I see the histology of the patient, and we can estimate the weight of tissue removed, I will publish it on the comments later on. I don't have it at this stage that I know of. Maybe we can check, because I had opened the clinical record of the patient right in front of this video. No, we still don't have the histology yet, so I will place it on the comments. And that's the, there was a little bit of adenoma there, you see, but it's relatively close to the UO, so I chose to vaporize, that little bit of tissue there. It serves as a hemostatic, and, trying to remove this little bit of yellow tissue. The fiber measures 0.5 millimeter, so that probably was a 2 millimeter or 3 millimeter bump of tissue there. And now it's the time to move on to morcellate. So there we are. This is the review of the fossa, the trimming phase that we do. There we are. So you can see the trabeculated bladder. So this patient had problem with their bladder function due to long-standing, probably obstruction, and probably the selection of the operation was not the best for this case. So I think as urologists we have to remain critical, and we have to acknowledge that there was a recent review where they say that in minimally invasive treatments for BPH literature, up to, I think, 60% of the papers have a heavy influence by industry. So we have to be critical and not just read the abstract, but read the paper and try to understand what is happening, because we have seen it. We forget history, but in history of urology, we have seen many hypes of BPH treatments, treatments for incontinence and such. And after the hype comes the deception, because people believed that the new treatment was going to change things, to painfully understand that the change didn't happen, and even heavily promoted treatments in the past are now totally abandoned, like tuna, microwave. There were so many surgical options that didn't live up to the original promise. No, so we have to learn from history and be cautious when we adopt a new technology, and then, of course, be very critical and very honest about the results we're getting, and then decide. One of the very nice things of offering HoLEP is that you have an excellent operation in your hands. You have a high degree of patient satisfaction after HoLEP, and I always say that these are the happiest patients that we see, and we get all the good things. We get very good flow, very good bladder emptying. We get probably the biggest, let's say, improvement that a patient can see after BPH surgery. We see all the good things, and with this Bloc approach, and with the early apical release and the preservation of the mucosa, and with careful manipulation of the endoscope, and bringing the adenoma to the middle, trying to reduce the traction on the sphincter, I think the incontinence rates are very, very low. Of course, we see the occasional case where a patient suffers from incontinence, but it's usually not huge incontinence and temporary in the majority of cases. And even patients who had incontinence at the beginning are very happy afterwards. So I think it's really nice to be able to do HoLEP, to offer it to your patients. And I publish these videos with the hope that people will get convinced and will start learning, because I think it's one of the most gratifying operations there is. You feel that you're doing something for the patient which is really good. And I have to say that, if you travel to America, you know that you can find patient support groups for all kinds of conditions, like urinary incontinence after radical prostatectomy. You can find for erectile dysfunction after radical prostatectomy, but there is no single patient support group for patients damaged by retrograde ejaculation. And we see a lot of activism by industry trying to tell us how patients want to ejaculate, but the patients themselves are not telling us how unhappy they are with their retrograde ejaculation. So we have to keep in mind that when we have a patient in front of us, we have to be honest with them. We have to tell them about the options there are, but we have to tell them about the limitations of the different approaches, the risks, and tell them what risks do they have in our hands compared to other treatments. So one more video for you to watch, and I hope you enjoyed, and I'm happy to read your comments. And this was the end of the operation, and the catheter was withdrawn the following day. The patient peed very well. I'll keep you posted. Thank you very much for your attention.